Hello everybody, I'm here at the Heart Failure Association Congress of the ESC in Lisbon, and I'm very pleased to give you some idea about the RELIEVE-HF trial in intra-atrial shunt. My name is Stefan Anker, I'm from Berlin at the Charité Medical School, and enjoy the show. The RELIEVE-HF trial is a sham-controlled trial of using intra-atrial shunts in patients with heart failure across the spectrum of ejection fraction. And the importance is that we really try to clarify whether this treatment concept could work either in patients with heart failure and preserved ejection fraction or in patients with reduced ejection fraction heart failure. This trial basically tries to pave the way for an additional new therapy for these patients at need with quality of life improvements, hopefully, but particularly with reduction in event rates. And this is what we investigated. Yeah, the shunt system is called the Ventura system. It's a small device put into the septum to allow increased pressures to be relieved from the left atrium and basically organize some flow to the right side, thereby decompressing the heart, making it structurally and functionally better over time, and hopefully over time then have also benefits for the patient otherwise. We enrolled 508 patients. About 60% were heart failure patients with preserved ejection fraction, 40% were patients with reduced ejection fraction heart failure. The patients basically were, as you classically see them, more than 70 years old, rather symptomatic, mostly in New York Heart Class 3. These patients were heart failure patients extremely well treated. Just to give you an example, the HFrEF patients had more than 70% in ARNI, and so this is the classical modern today's heart failure patients recruited in 11 countries and is as good as it gets with regards to standard modern heart failure. Well, this is an interesting study. Overall, we should say that the event rate kind of analysis combined with the quality of life analysis in the form of a win ratio analysis showed a neutral result. But the trial was a trial that was designed effectively as two trials in one. One for HFpEF patients and one for HFrEF patients, and using a divider of 40% ejection fraction. Both groups of patients were separately randomized, and that's called a stratified randomization. And so we investigated the key subgroup of patients with and without this reduced ejection fraction. And we found a dramatic difference in the event rates for the patients with reduced ejection fraction, where the shunt actually reduced them. And unfortunately for the patient with preserved ejection fraction, the event rates were increased. This was to some degree surprising. This was highly significant in terms of having one kind of a result and another kind of result in the two patient groups. And so we must say that the overall conclusion, as true as it is that we had a neutral finding, needs to be added, an asterisk if you like. There were strong subgroup differences, making it not possible to just say it doesn't work. It just works in one group of patients, the HFrEF patients. Shunt therapy might be a little bit more complicated than we thought. We have actually maybe some patients where it absolutely doesn't work and maybe even negative. And we have patients where it does work, and it appears for the Ventura system that this is heart failure patient with reduced ejection fraction. Of note, there was a previous study with the Corvia system where it was particular patient with low pulmonary vascular resistance on an exercise test with exercise hemodynamics being assessed, and this was the responder group in their trial. So we need to figure out really who is benefiting. We are optimistic that this can move forward with heart failure patients in reduced ejection fraction, but basically let's see how everybody reacts to this. Well, there is additional patient cohorts of need, and they will be investigated. And the future will tell us really how much we can explore all of this, but definitely more studies will be done.